But let's go to this case. 61-year-old patient has chest pain symptoms and has a multivessel disease, mild LV dysfunction, and rest of the parameters are shown. This patient has a RCA PCI done, and then today is the for left main LAD and circumflex, which I want to show. The medicines, you know what? We are following more of a orbiter 2 trial pattern. PCI alone without much medication.
Yeah, there you go.
Okay, let's go. So we have answer for it. Guys, the clicker is what happened. Somebody threw away the clicker? All right. Okay, good. So if we can go to the patient, the right, which we fixed it last week. So just to say, lot of cases which we say the multivessel, high syntax score, left main. One of the reason is the referral pattern at Mount Sinai. I do, let's say, 120 interventions per month, 120 to 130. 50% of them, 60 plus, are referred by other people, many of them interventionalists, because patients do not want cabbage. And that is that's how our pattern is. That many of these patients, because we know that those who don't want cabbage, those patients will find somebody who will do the PCI. And I have a good network of our physicians who continue to do sending us the cases, and that's where we are. So cases, many times it comes down that how come patients are not being referred for cabbage. Largely, we have our paper just came out about patients who refuse cabbage versus the patients who should have gone to the PCI based on the OC criteria. And of course, third group is patients are ineligible. And turns out to be patient who refuses cabbage compared to who are justified to have PCI. So one is the OC criteria, PCI appropriate. Second, patients who refuse cabbage and still have a PCI, and we basically go through that process. Like not this patient came from outside, so we need to do PCI. So otherwise, patient comes out of the cath lab, meet with a surgeon, and this is their outcome actually was a little worse than the PCI done based on the OC criteria. So yes, these patients are a little high risk, but can safely be done compared to ineligible patient. So second is the point about the rotational atherectomy or any atherectomy. As you know, the New York State also tracks all the atherectomies. Our number is about 22%, and partly because of largely because of the referral pattern. And in the New York State, it is about 6.8%. And that is because we represent 10% of the New York State volume. If they take out our volume out, it will be the same about 5%. That is what for ACC and CDR. The third question basically was that how long you can use the burr. David Oth, we asked that question. He said the burr is good for 300 seconds. So 300 to 350. If you're done 300 seconds out, then burr loses its efficiency, then you need to change the burr. So 300 seconds is the kind of time if you need to change the burr. I'm sure some cases you can do even sooner. And the point, we do 150 RPM, but if it does not go through after 5 runs, we go to a 180 RPM. Those are the various points I just wanted to say. And let's go to this case presentation. This is the case with the distal left main and 2 lesions in the ostial and LAD and ostial circumflex. I'll just complete in terms of the OC presentation in this particular case, making it M. Say, rest of the team is about the same, except Parusram changed. And my fellow-wise, we change also is Pierre and Chandrasekhar still remains, and our cath lab staff and imaging are all same. So with that note, we want to just go to the angiogram now. So this case, let's say.
Maybe you can show us the angiogram before the wires.
Yep. Yeah, it's angiogram. You have it now. It's coming. Same, we just do a little injection. Yeah. What is happening today?
Yes, we have to show it to us.
Okay. Good LV. And the right coronary, which we did intervention a few weeks ago, we always check that. And then we go to the left. Here, it's a kind of a 0-1-1. Very ostial, 90+% ostial circumflex. There is a stent many years ago done in Bangladesh, and then very calcific proximal LED on the top. I mean, not a severe calcium, but enough, which we say, based on the angiogram, I would call it a moderate to severe calcium. Then we did the OCT just to complete, because today we said all the cases we'll do with the imaging. and we are able to do, and the technique, basically what I do, compared to using, other power injector give too much dye. You see the guide liner or Godzilla right there, and then you give a small amount of dye. But it still have to dye. Yeah, a lot of people do actually with the saline, but pictures never comes out good of the saline, particularly the left side, right side, maybe. But even in respect of the creatinine, we try to do the cases when OCT need to be done. So maybe Kiski can just show osteal LAD calcium. Yeah.
The one thing, though, is important if you're going to do it this way is you definitely have to tell your fellow to hold on to the guide extension, because if you see what happened during the picture, the guide extension gets ejected from the left main into the proximal LAD. So that's just something to be cautious of. And then you miss seeing the LAD potentially, or the osteum.
Well, both. Let's see what you have. Can we see what you got? Because that's the first thing I saw as well, that the guide extension fell past the lesion.
Sure.
Can we show the OCT, please? Yeah.
Sure, I'll show you. Okay, so this is a proximal LAD coming proximal. Now the EEL is like a 4.0 vessel. Now come to the proximal LAD. It like automatically detects like 200 degree of the calcium. Yeah, and a maximum calcium thickness is like 0.9. Yeah, and as Dr. Ajay mentioned, the guideline is sucked in, so we cannot see the tightest part. But in terms of the calcium degree, it's more than like 180 degree, and the thickness is 0.8, and the longitudinal length is more than 5 millimeters. It's a severe calcium based on the OCT.
So our OCT score will be 3. So based on that, we did a 2-0 bar. Sorry, you just show it, which was not trouble.
It's a pretty discreet, Dr. Sharma, just because we've been talking a lot about how do we modify this plaque. It's a pretty discrete area of calcification, severe, both superficial and deep, 360 degrees. This could be pretty much any device could work here. Is that right?
Yeah. Oh, yeah. Yeah, definitely.
So
you can
could
use
you talk
IVL,
about that? Because
it
just seems like you're loving these burrs. So let's make sure there are other choices available.
I can say the burr made the life. With that note, all the nothing personal investment. But yeah, so key is what I say basically is just you can have various ways to deal with it, but you try to do and show people what you do the best or what your usual pattern is. This is the type of case we do a rota, and subsequent procedure just become a little simpler and shortened. Many times end up in doing 18, 20 PCIs a day. So the complex cases, by using the atherectomy, rota about 80%, orbital about 15, 16%, and 4% laser. That's what in our lab. But yeah, this kind of case, I think I agree, because the lesion was there about 80, 90, 80%, but IVL could have gone in this case. Or other one is you want to just do a cutting balloon. Cutting balloon always is a trouble. That is a good, Wolverine, but you always will have that calcium behind and never get a good lumen. So I definitely would say once you have a OCT score of 3 and above, you said 1, 2, or 3, is a 3 and above, you'd want to modify it before you put a stent. So therefore, in this case, some type of atherectomy or IVL will be preferred, not just the cutting balloon. So that's what we did. And then we put a 3.5, this is the Wolverine. At 16 to 18 atmosphere, you can go without any problem. And then we went to other view for the circ. Circ is a very tight, you can see there now. Clearly, we used a 2.5 balloon first. We knew that 3.5 cutting, the Wolverine will not make a turn. And we use a balloon followed by, this is the Wolverine. And this is where we are now. And we are ready, taking advice what to do. We have a distal left main. Truly, as I said, it's a 0-1-1. It still will make a criteria for people who are doing the DK crush or mini crush. We are ready to stent it now. So you can ask your panel what type of technique will be done with this left main while we are trying to advance our stents.
Yeah, I mean, I think obviously this is a left main biosteal disease, however you want to call it. And I'm surprised you didn't use imaging on the circ. I probably would have done that as well, just to get an idea. But it looks like you were pretty, you were able to open this, and there was some plaque shift right after that balloon dilatation. Obviously, this is a 2-stent. Let's just take it down the line. Dr. Fox, we haven't heard from you. Maybe you could tell us what would be your strategy here in terms of stent strategy.
Yeah, I would use 2 stents, and I'm a big fan of the Mini T, or Mini Crush. Either one of those two, I think, would work well. Just wondering, did you think that was peristent restenosis in that circumflex?
Yeah.
Or,
yeah, I think it's just about there.
edge
But,
restenosis.
Looked like it's
within 5 millimeter, it was there in the 5 millimeter.
looks like it stayed very stable with all your
Yeah.
work that you did in the LAD, which was a good sign. And usually, peristent restenosis is very expandable, very treatable, and slippery. It's slippery tissue to make the turn like that. So I think you're in good shape in
That's
that
good.
regards.
Let's hear from Dr. Ichaporia and then Dr. Waxman.
Yeah, no, I like the mini crush. So I like the idea of the double stenting. So mini crush would be my way.
Mini crush, yeah. Dr.
And
Waxman,
as you know that
any
in the
other?
Europe, they
I'll
will
go for
split
T
up.
Nobody's
Still.
doing DK crush, double kissing,
I can tell you
multitudes
that
of crossovers and kissing and kissing again and re-kissing.
my experience with DK Crush, that there is a lot of restenosis. I get all of them back, so I'm not doing DK Crush anymore.
Dr. Stone?
Yeah, I would definitely do a DK crush. I think, Ron, if you get all that restenosis, you're not doing it right. So, I mean, the one thing honestly, John, I wouldn't do a tap here or a modified T because it's already an edge restenosis, and the one thing you don't want to do is miss the origin of that osteal circ, which there's a good chance that could happen. So, look, I think that they're both big vessels. I think you could do a mini crush, you could do a DK crush, you could do a culotte, because they're similar sized vessels, or you could even, I wouldn't recommend it, but even do a V-stent or simultaneous kissing stents.
Oh, yeah, no, please, no V-stents.
Key issue is to do
Ajay?
both.
Looking very good.
Ajay, last
Now we have
thing,
to recross.
before we go, Ajay, anything?
No,
Added?
no.
Okay.
I think, look,
We
there
covered it.
are a variety of ways to treat the bifurcation. The big advantage of the DK crush, though, is it allows you to recross more reproducibly and end with the final kissing balloon inflation. The big and you can do it in 6 French if you need to. But the disadvantage is, at the end of the case, you look at the floor and there's like 17 balloons on the ground and around and that kind of thing.
Yeah, but it does give you the best geometry to the osteal circ.
So, Dr. Sharma, what are you doing here? What did you decide to do?
No, we already have crossed the wire into the circ and we put a stent. You saw the picture here.
I'm sorry, I
This
was
is our
looking
pictures
at
now?
my panelists.
Yeah, right
so-
there. Yeah.
Oh, okay, I see
We're
what you
just,
did.
yeah.
You're finished.
And, we are just going to. No, but if you want to go there, because I know you have a lot of other things to do.
There's a mini crush.
Mini crush, yeah.
Mini crush, yeah.
Yeah, which I think
mini
is
crush.
I think you
fine.
have to rewire again, is this?
Yeah, you want to rewire,
Yeah,
you
I
want
did
to do
already.
a pot and a
rewired
final
already.
kiss.
Yeah, 2.5 balloon we have done.
I think the one thing here geometrically that works well for a mini crush is this is virtually a 90-degree angle taken off.
Yeah.
So you don't have to hang much stent out in there to still get apposition or coverage of the osteum.
Go negative.
So what I'll do is the 2.5 balloon which we had earlier to open the circ, we are going to go with that now, and then we do a kissing and then we do imaging. I mean, it's just to complete, so everybody else is happy.
Yeah, and it's important to do the pot here. I think that it give you good
And we'll go more
access.
to the circ.
It'd be interesting if you can image the circ as well.
Yeah, no, I think if we do, probably we do circ more imaging than anything else.
Right.
We need to
Your
cross.
guide is a bit out, Dr. Sharma. yeah.
Crisscross.
Yes.
No, guide is out, but wire probably crisscross.
The
So
wire
I pull
is
back.
crisscross, something is going on.
Yeah, that's what I thought it was to recross, yeah.
Yeah, no, we did earlier. We recross again. But only thing is now the tip.
Yeah, you may need more of a bend. There you go.
Okay.
We'll kind of also always routinely.
No, this is the used balloon. Now, this is the 2.5 used balloon we are using now.
Of course.
Is that a fresh balloon?
I said May.
It's a used balloon, 2.5.
It's better to use a fresh
and it's not
balloon.
Well,
going.
that's the one we used earlier.
70
Yeah.
degrees.
No, it will go. It will go. It will go. It will go.
It's already there.
Go up. Yeah. Yeah. And I think in the end, we have already seen the LAD on the OCT, and now we are going to do the with the OCT for the circ. Yeah, go up again.
So, I mean, the gain on the OCT was crazy high in this room. Is there any way, I don't know if that's coming from your end or our end.
I think it's been like that all day.
It's
from our
almost,
end.
you can't read
ready
it.
for
Let's
the
be honest, you
It's
can't
there
read the
and-
OCT from leading a lot of
Why
OCT
the
studies.
OCT picture there? It's showing the OCT pictures are not coming good.
Yeah, it's incredibly bright. Like the gain is
Yeah,
on
I noticed it in the
1,000.
last case as well.
Yeah.
Yeah. The connection issue, it's indirect.
I might add
Yeah, it's funny, it wasn't
a
happening on the
technique
Ivers.
point on
The Ivers looks
recrossing
okay.
of putting the
Whatever
wire down the main
interference it's
vessel
getting,
and
but-
passing the balloon
Get the
into the
four.
main vessel before wiring the side branch.
This is 3.5.
Yeah.
I will kiss out of 3.4.
Okay. So we have 3.5 high pressure for the circ and 4.0 for the LED, and then a little proximal. We can just make a pot with the two of them. I know a lot behind that, pot before, pot after. But as long as you have nice lumen circular open nicely, and particularly you have the OCT, which tell us you got a good results of your. Okay. Get a 4.0. So, Roxana, what is the plan now in terms of your debate?
Well,
or
we'd
your
like to
lecture
watch
and the
you do
debate?
this, and then we're going to go
Good.
to Dr. Kurtenay, if
Good.
you're okay with that. Just want to see you
Okay,
place
good.
this,
Yeah, yeah.
do this mini crush.
Yeah.
Maybe you can walk through it for the audience, please, one by one. You just, as you
Yeah,
saw
no, the
this,
mini crush, they showed the app earlier. So
Yeah.
basically, we saw the circ was 3.5, and now this is the 4.0 in the LED. That's where we are now.
There you go.
Recrossing. Now, there is a science behind whether to do proximal strut, mid strut, all that. You know, as long as you go to a good strut, go up. Yeah, that's what I say. So you go to the good strut. People ask, do you go to the proximal or distal? I say, I go to the good strut. Good, negative. And then proximally, you can always do
a little bit of
make sure with the proximal edge.
Yeah, the edge
Yeah.
has to be a little bit better.
Yeah. Good. Go up again. I think we have full coverage at the proximal ostium. Negative 3.
Good.
Okay, so what we are going to show, the angiogram and the OCT of the circ. Is that okay?
Yeah, that would be great. If you just show us the angio. And the
OCT of the circumflex. And just want to say that we are doing it for the symposium. For all the faculty, you know, in real life, we never do this.
No, I would do it. But you know what, last year, Greg, this year they blamed you, but last year at the last case, Dr. Sharma said that we've somehow turned into the Columbia Cath Lab.
Every case was done with the Ivers. Yeah. No, I would say that just to say. Huh?
This looks good.
Just get it.
Very
Yeah,
well done,
very good.
Dr.
So
Sharma.
just want to prove
And
it, yeah.
geographically, it looks good, but now let's see if it's really good.
Yeah.
Can I ask? Yeah.
That's the way it was always, a little bit. That was more of the diagonal origin. We'll go to other view on that.
And then please
So
fix that wire in circ. It's bothering me.
Yeah, it's bothering me too. It's in a little tiny branch somewhere.
All right, yeah. All right, let's get the tiny branch out.
I know. He was very fast. Yeah, it likes that branch.
You're back in that tiny
It
branch.
likes that little branch.
I know. Yeah, so we'll try to, once we are there, let me just readjust there. So we'll just keep it a little proximal.
Okay.
Yeah.
Okay, put your OCT.
The nose of the OCT is long.
No, we'll go to the main vessel. Happy?
Nice.
Everybody
Much
good?
happier, yes.
There you go.
Yes.
Now we're happy.
Yeah. Okay. So make sure, guys, the Gardella, it's a Gardella guideline or what is it? Gardella, make sure we hold it while injecting.
Yep.
Okay, very important. Good.
Could you show the OCT screen?
Just make sure you tell us what to do. Where we should put, how much we should inject.
No signal.
Sorry, Dr. Sharma, it's an indirect image. No,
And they say it's too bright down there.
yeah, because indirect. I'm sorry.
Okay, it's not even going.
It's bright.
Remember last year, if the people recall,
Wow.
I put up the same thing happened 2 times, right?
Supernova.
Like looking at the sun.
It's very bright.
Let's see the
Looks like a
fluoro.
supernova.
SS, we have to see the fluoro.
Need the sunglasses.
Yeah.
Okay.
Yeah, see?
No, you are not the fluoro?
Now we have the
Now we
fluoro,
have the
yeah.
fluoro.
We have the fluoro now. It's too much angulation. That's why it's not gonna go.
Okay. Look at this.
It doesn't close.
This is
Yeah,
OCT.
I was talking to Greg about this. So much angulation and so much metal for the OCT.
Yeah, mostly iris.
So what can we do? Look, we can rewire it.
Forget
We
it.
have rewired
Forget
few
it.
times.
Forget about it.
Okay. Okay. No.
Oh, there's lots of things. There's lots of
something.
things you can do. There's tons of things you can do.
Yeah.
Okay, yeah, okay.
You can use a buddy wire, a buddy balloon. You can put it through a extension catheter. There's lots of things you can do.
The issue is the distortion of the
Different
stem,
wire.
the
There's
accordion.
lots of things. You can cross it if you wanted to.
Okay.
The one thing you don't want to do is distort the
Yeah, let's
stem.
do the LED.
I think a guideline I can come back. Yeah.
Yeah, take care of the micro
It's better to show the iris stuff.
It's better.
Okay.
Yeah, 1 second.
That
Enabling,
doesn't
1
look
second.
good to me.
1 second. Calibrating. 1 second. Yeah, please, Cine inject.
LED should look great.
Residual blast, sorry, bad image.
Image did not look great to me.
Yeah, no good image. So
Please
we
go
can
in
try.
now.
Kind of disengage. Get out.
Yeah. All right. Can we show a little bit or no?
No.
Huh?
No.
All right.
So we can start more proximally. Now the camera is in the guide.
No, it's not going to go there.
You get accordion the stem.
I think that's enough.
Yeah, don't mess
Yeah.
up the stent
no,
now
just
that
forget
you
it.
just
Yeah.
put in.
Yeah.
Okay, well,
I think, but you see, if you are okay, I think that's okay. I'm happy. Believe me, this we are doing it for the audience and so.
Yeah, that
but I
looks
think
really
it's
good.
Okay.
all right,
It looks
that's really
beautiful.
good. I think we will
Congratulations.
stop right